afternoon, everybody. Let's start.
Good afternoon, everybody. I'm Untitled. Yeah. I'd like to talk about interaction between pre-existing tuberculosis and smoking history on the risk of lung cancer. Actually, we concern much more the TB as an outcome of human health. But we also think about TB could be a causal factor of other diseases. In particular, as we well know, there are lots of reports about the chronic inflammation could be associated with the cancer disease. In addition, there are several studies also try to investigate the relationship between tuberculosis and lung cancer. And then there are, as you can see from the this table, there is a meta-analysis to identify the association between TB and lung cancer. There is a debate about the TB, if TB is real cause of lung cancer, because we can simply think if patient diagnosed as TB, the risk time to detect lung cancer could be decreased. So maybe the increased risk of lung cancer among pre-existing TB history patients could be a bias by the risk time bias. But in this meta-analysis, in the bottom line, of course, there are some risk time bias can be observed in here. After people who diagnosed as TB right after 1 or 2 years, there is increased risk of lung cancer detection. But in the long-term follow-up, there are still significant increased odds ratio of the lung cancer among the pre-existing TB patients. So we can clearly conclude from this table tuberculosis might be considered as a cause of lung cancer, but there is limited information of after adjusting the smoking history as well. The TB still have a significant factor of lung cancer, but there are little studies about any interaction between TB and smoking to increase the risk of lung cancer. So that's our question. As a methodology, we extracted data from the National Health Insurance Service sample cohort from 2002 to 2013, and then among them, which is include about million patient information. Among them, 10% take the regular health examination. In the regular health examination, there are some information about this measurement. So TB case could be defined as a self-reported previous TB history, and then smoking history they report, and lung cancer can be defined as the ICD-10 code. And 11 years follow-up period conducted in the study, and potential we considered age, gender, income, BMI, and drinking and exercise history as a potential compounder, and then we constructed multivariate stratified logistic regression model, and then in addition we also analyzed to understand the interaction with the multiplicated scale and additive scale. This is simple result. About 83,000 cases were included. Among them, 1,400 lung cancer cases were detected. In this simple table, there are high risk of lung cancer among TB history group and the smoking history group. This is the final table. The no TB cases who has no TB history and no smoking history could be considered as a reference. As you can see from the table, the odds ratio, adjusted odds ratio was increased each strata. But we tested the interaction with the additive and multiplicative scale. There is no evidence about the synergistic effect between smoking and pre-existing TB history. So this is discussion's brief summary. Smoking and TB history independently increased the risk of lung cancer, which is really consistent with previous literature. But there is no synergistic effect between smoking and TB history to increase risk of the lung cancer. But this study is also has some limitation, including the misclassification bias and recall bias. And then, what if you can think about the TB patient or people who diagnosed as TB, they can quit smoke. So those kind of cases cannot be categorized as the current smoking group. So it also could affect the final outcome.
Thank you very much. We have time for
1 minute.
Yeah, one to two questions at most.
Is there ever a consideration with these types of studies that the TB diagnosis is making people look more carefully for cancer?
Careful to detect cancer.
Yeah, so their awareness is heightened.
There is an assumption, but we don't know. We don't identify the possibility in our data set. But simply, previous studies also mention about those kind of possibilities. So that's why maybe as I showed, but the meta-analysis also report the very high risk of lung cancer within very small period after TB diagnosis.
Right, that's what made me ask. The ones who are being diagnosed with lung cancer very soon after a TB diagnosis, are they being diagnosed with lung cancer because during their TB treatment it was detected, or the TB workup it was detected?
The next speaker is Mr. Gali?
Yeah.
Yes. Tobacco cessation intervention of civil society plays a vital role in treating experience among tobacco using TB patients.
Good afternoon. I'm Kiran Kumar Reddy from India. So I'm going to present you tobacco cessation intervention by the civil society, how the civil society has played a key role among the pulmonary TB patients who are mostly lost to follow-up cases in one of the South Indian district, which is called Bijapur. So we have taken a sample of one TB unit, and I'm going to present that one. So the objective of the study is to quantify the efforts of the treatment outcomes of the tobacco smoking pulmonary TB patients through the tobacco smoking cessation intervention by the civil society organization. Before I go through this one, I would like to, it was one of the civil society, it is Seva Sadan, which is run by the Sisters of Charity, Catholic nuns, and they have the comprehensive CCC program, comprehensive care unit, and along with that, they have planned for this study. So before that, I will show some of the statistics for the India. India has the world's second largest tobacco growing industry, and we have the current tobacco in India from 34% nearly, and the current tobacco smokers around 14% adults, and the users of smokeless tobacco is nearly 26%. About the 10 adults, every 10 adults were exposed to the second-hand smoke at home, and nearly 600,000 people, men in the age of 25 to 69, is died due to tobacco every year. And this was the district we have chosen from the South India. The district is named Bijapur, and it has the population of 21.75 lakhs, and it have urban population 21%, and mostly 78% belongs to rural population. And the district is consequently getting the high default rate among the pulmonary TB patients. So the district authority consulted civil society organization to study for the causes and reasons for the last follow-up cases, especially under that particular tuberculosis unit. So the methods are chosen by the civil society organization with the help of their volunteers, 10 community volunteers, and they have mapped the area of the tuberculosis TB unit, and they have done the palliative study of that. They have interviewed the all the patients, so pulmonary TB patients in that particular TB unit, and they have collected the data before going to the study. And next after that, they have a prospective collaboration efforts with the program of the National Tobacco Control Program. They have collaborated. They have taken the technical assistance, cessation counseling, technical training from the National Tobacco Control Program. India, we have a separate revised national TB program and tobacco program. It's the independent units, and there is no such good association. I mean, it is an initial intervention started by National Tobacco Control Program. So now we try to, with the help of civil society, we try to link between assess the services and get the services of the National Tobacco Control Program, cessation counseling services for the TB program. This is the first time we have piloted in the tuberculosis unit, and the counseling was given to the periodic counseling for the pulmonary TB patients who are the last follow-up cases, who are the consumers of tobacco in different forms, smokers and non-smoke and smokeless products they use. So they have given a periodic of 6 to 8 months consecutive counseling, and the results are. And this was the study intervention. And before 2014, in the 2014, they have the cluster of 375 patients. Out of that, they have 274 patients who are the tobacco consumers, and the source of the data is taken from the government TB registers, and the default rate is noted as in 13.1, and the death rate is 8.5 before the intervention. After the tobacco cessation counseling, the results are analyzed. Post intervention, we have out of 295 TB patients, 218 patients are tobacco consumers in that. So from that we got the 7.1% default rate, I mean last follow-up cases, and death rate is reduced to up to 6.8. And this was a pictorial presentation, pictorial view of that precise data. And conclusion says that tobacco cessation intervention counseling played a vital role among the pulmonary TB patients who are consuming of tobacco, and which gives to reduce the death rate, as well as this model can be replicated to other tuberculosis units which is having the high tobacco consumption. This was the draft. This was the abstract data, and the full-fledged study it is started already. It will be going to complete maybe another 3 more months. Thank you.
Questions? Yes.
Thank you for an interesting presentation. I was just wondering, intervention itself, was it only, did it include also tobacco cessation treatment, or it was just counseling on side effects of smoking, secondhand smoking?
Yeah, see actually the process is like this. During the counseling, there are initially during the process of counseling, initial first 2 months, many patients are reluctant, they are not interested in the counseling. They don't want to, first of all, they don't want to quit the smoking, or they don't want to quit the consumption of the tobacco products. So the counseling has played a vital role, and we have also some side effects, we have also some trauma, something like other factors of medical threats. We have taken the help of technical support from the National Tobacco Control Program, which for physiotherapy support and all these things. It is not related only the smoking, and also other form of consumption of tobacco.
Yes.
Yeah.
I think you were first. Yeah. I think.
Thank you. Very interesting presentation. And my question is, who did the counseling? If it is the research staff, then what about the scalability?
Actually, the staff, actually, the NGO, that civil society organization, they have their own staff counselors. It is community volunteers. Actually, they have received the training from the National Tobacco Control Board, which was WHO prescribed counseling module, which is introduced in India. So they have taken the counseling from them, and the civil society organization itself, their staff itself, they have given the counseling.
I just wanted to ask if you measured any other outcomes other than the fall in death, like TB cure or treatment.
We mostly concentrate that, but in full-fledged study, we are going to assess the other social factors also. We are going to assess the, especially the among the women tobacco consumers. So they used to smoke less tobacco consumers. And as you know that we have previously in India, we used to get the betel nut with tobacco product together. Now government has separated the betel nut and the tobacco separate. So which is for tobacco consumers, it costs more. It may be previously it was $3 maybe $3 maybe. I'm taking in the rupees, 3 rupees. Maybe it costs now separate. They have to purchase it, and it may cost around more than $7. And now they have, that's why, and in villages they are doing this betel nut with it's kind of one of the drug called ganza. It is a local drug which is available illegally. They used to sell it for the only $2 now, and poor village people who are illiterate, they used to purchase that. It is widely available, and we are going to definitely assess the other co-factors associated with this study. And we come across some of the few pediatric patients, pediatric TB patients who consumes the smoking product, and which is very sample size is very less, because we found that during the interview them, what the inspiration they got to consume that, because their parents used to send them for the shop or grocery store to buy for them the cigarette or other tobacco consumable products for the parents. They used to send them shop. So they inspired from the parents, most of them, and they used to attract towards that. That's one of the factors. Thank you.
Thank you very much. Now for L. Dacia, about smoking, actually about the healthcare workers at TB facilities. Thank you.
Good afternoon. My name is Lash Dacia. I'm representing country of Georgia. As a brief background, as a clinical epidemiologist, studies have frequently reported that patients with the TB who smoke are increased the risk of TB outcomes, including relapse and death. Choose patients with TB case smoking before the TB treatment may reduce the risk of poor TB outcomes. However, little is known about whether healthcare workers in TB facilities believing that smoking impacts death of their patients. Additionally, if healthcare workers in TB facilities who smoke have different attitudes about the relationship between the patient smoking and TB outcomes is unknown. Therefore, the study aimed to first estimate the prevalence of between TB facilities smoking among TB healthcare workers in Georgia, and second, determine the attitudes of healthcare workers at TB facilities regarding the impact of tobacco use treatment. Eligible participants of study including the adults healthcare workers around TB facilities in Georgia. Surveys were collected by the paper forms. It was anonymous and self-administrated. The table 1 presents the distribution of smoking status by the healthcare workers' characters. Overall, 431 healthcare workers at TB facilities completed the survey, and most of participants were nurses, female, and the main age was 15 years. Overall, 59 from 431 participants, 59 was healthcare workers, currently smokers. It's about 13.7%. Among TB healthcare workers, significantly high proportion of physicians who were self-reported that they are current smokers. For example, nearly 90% of physicians reported that they are smokers, comparing with 9% of nurses. The next, when we examined the knowledge of attitudes of healthcare workers regarding stopping smoking cessation. Healthcare workers were asked if they ever heard about nicotine replacement programs, or they even have some kind of training. Over the 2/3% of physicians and participants had known that they haven't received some kind of information, and they didn't know about this. However, only 26% of healthcare workers respond that they received some kind of formal training, and it helps patient to smoking cessation. Overall, 62% of healthcare workers believe that their advice will quitting smoking and improve the patient decision to cessation of smoking. We didn't detect statistically significant difference comparing physicians and nurses regarding their attitudes about smoking decision. Next we run a multivariable logistic regression model which examined association between the healthcare worker smoking status and that smoking doesn't impact TB treatment. After adjusting the age, sex, years, education, we found evidence between the smoking status and healthcare workers' positions. The smoking doesn't impact TB outcomes among physicians who currently smoke, 3 and 8 times odds believing that smoking doesn't impact TB outcomes among physicians. At the conclusion, we are reported 46% of TB healthcare workers were smokers, and only 26% of healthcare workers received training past. The belief that smoking doesn't impact TB treatment outcome was common, and belief was different among physicians who was currently smoker. In addition, our data suggests increasing the training opportunities among healthcare workers, TB healthcare workers, which will provide the TB patient may attend smoking cessation efforts. Thank you very much.
You can have 2 or 3 questions, yes?
So thank you, very interesting and disturbing. That so many healthcare workers and especially physicians don't A, smoke, and B, seem to have no regard regarding their actions towards patients. So I was curious, you said that 75% of them did not think that smoking was bad for their TB patients.
Yes.
Did they think smoking was bad for other comorbidities or other illnesses?
Unfortunately, we haven't some kind of question, but regarding that they haven't receiving any kind of information previously in education, in university, they thought that it was just nothing. Even the comparing that it was bad for their lungs or health. It's a problem of education, and it needs supporting some kind of training, guidelines, and policy.
Right, well beyond TB.
Yes.
Any other questions?
Can I ask a question? So,
yes.
Yeah, very interesting study and an eye-opener. Do we know what's the smoking prevalence in other health workers, non-TB health workers?
Unfortunately, it was the first some kind of this study in Georgia with the healthcare workers, and previously when I found out the statistics in local NCDC statistic department, there was 1998 which was conducted at Republican Hospital. It was after Civil War, after 5-year Civil War, and there was conducted about 500 healthcare workers, and most of them, about 34% were smokers. Yes. But it was only one, and it was the different kind of departments, not only the TB, it was, for example, ER, the surgery department, ophthalmology, gynecology. It's a main hospital of Georgia. Yes. That was only one, and it was second one which conducted among the healthcare, because there are many rules and bureaucracy conducted with patient and conducted with the professionals. Yes.
Thank you. Was this all? Any more questions? Okay. Let's go to the next presentation. Pavilial. Sorry. That's not sorry, that's I don't think that's correct. Is Pavilial not here?
There's no presentation.
Oh, all right. Okay. Then let's go to Mrs. Shangasi of South Africa. Yes. Thank you. Yes. Yes.
My study is based on, or was based on, identifying barriers to smoking cessation among drug-resistant TB patients in South Africa, in KwaZulu-Natal, which is based in Durban. And when looking at the background, in South Africa, drug-resistant TB patients, it has been noted that there is significantly caused more morbidity and mortality among drug-resistant TB patients. And also an association has been noted between long-term health effects of smoking and the adverse TB outcomes among drug-resistant TB patients. And also a prolonged period of infectiousness has been noted, not only in South Africa, but also in other high TB burden countries. And I carried out my study at King Dinizulu Hospital, which is based in Durban, South Africa. And the design of my study and the methods it was a qualitative design that included in-depth interviews with drug-resistant TB patients who are smokers, and they self-identified themselves, and I managed to interview 15 males as well as 5 females who are smokers. And within my methods, I used open-ended questions where I was inquiring around smoking behavior, like how many cigarettes they smoke per day, and so on and so on, and the times of the day when they smoke, including the knowledge that they have regarding health risks of smoking, especially why they are infected with drug-resistant TB, and also being on medication. And I also inquired about their interest in quitting, whether they intend to stop smoking and when, whether immediately or long term. And I also find out about whether they know of any cessation support that is available to them and what their preferences would be. And I recorded the interviews and entered them on in vivo in order to generate stems from the interviews. And my results, I find out that the patients, all of them, were not aware of any smoking cessation interventions within the hospital, including the clinics from where they were referred, because they get referred from the clinics to the hospital. And also, they felt, although the staff does mention, that smoking is not good for them since they're infected with TB, but most of them called it preaching. They said, staff always preach, but we do not have any practical help to stop smoking. And they mentioned cravings, that even if they do feel or want to stop smoking, but due to the cravings, it becomes difficult to sustain smoking cessation. And one of them actually mentioned how aggressive he gets if he really needs to smoke because of the long-term smoking behavior. And also, since they were admitted in hospitals, some of them had to stop working. Most of them had families at home, or they were single parents. And they mentioned that while in hospital, some of their colleagues or other patients die, and they also fear for their lives. And one of them showed me a picture of a lung where one of the friends who was in the hospital coughed out the lung and he died. So they used smoking as a coping mechanism in that manner. And they easily acquire cigarettes while admitted in hospital. They buy from the tuck shop from other patients, or family members bring cigarettes to them. So in they have various means of acquiring cigarettes. It's not a problem at all. And also now there's a serious issue here on stigma. They felt that if someone does reveal that they smoke, there's a stigma behind it because they know they're infected with TB, and staff feel that they're supposed to have stopped smoking. And one patient reported that if he starts coughing at night or it complicates and needs staff to attend to him, staff would be shouting that because they smoke, that's why the medication is not responding, and so on and so forth. And there's also a link to staff attitude. And they felt that the manner in which staff communicate with the smokers is not helpful at all, because they mostly get chastised for smoking rather than being supported practically to stop smoking. And a few of them mentioned that they have nothing to do while admitted in hospital. They have to get up early for examinations and for their medication, and they just sit around. Even if you go to hospital, you find them sitting around there, talking or just socializing, or in bed. So for the whole day, they have absolutely nothing to do within the hospital. And the conclusions, I feel that these findings indicate the need for a holistic approach to smoking cessation, which will include the factors that I have already mentioned within the results. And many patients did expect the need for nicotine retention therapies, which would support them practically, and also for psychological support while they're in the process of stopping smoking. And additionally, extramural activities of various means could be quite helpful to the patients, so that they wouldn't have a lot of spare time where they think of smoking. And actually, one of the patients who is in their 40s, he's a professional. He mentioned that while he's at work, because he does a lot of physical work, he smokes less because he doesn't get time, spare time to smoke. He does a lot with his hands. So the more they work with their hands, some feel that they will smoke less. Thank you.
Questions about this new area, this other topic of actually MDR-TB and smoking cessation? Yes.
Thank you for your presentation. What is the involvement of the social workers in
social workers?
Yes, in the development, in the treatment of the
that's a good question. Actually, I did have interviews with staff as well, social workers, clinicians, as well as nurses. Social workers, what they claim to be doing is just supporting them with poverty, those who face poverty, patients who face poverty. But they have no support for smoking cessation at all. So I feel that when I design, because I need to design an intervention model, that is when I will include them. And from the interviews with staff, clinicians as well as nurses feel that they are burdened with the patient. They do not have time for actual interventions like smoking cessation, and they recommended the social work department for that.
Because why I'm asking is because in some countries the social workers are involved in assisting with extra activities like putting up a gym or something like that to help the patients to better to spend their time in a more productive way.
Yeah, so I feel that they really need to get involved. So I will explore their role even more, because it's them actually refer. Once the patients are discharged, whoever has been under the care of social workers get referred to community services. So it might be easier to follow up patients if social workers get involved.
Thank you. Thanks. Yes. Let's have a look at something very different now, modeling and what would be the impact on actually TB in Indonesia.
Thank you.
P. Wagner.
Yes, so thank you very much. So this is a little bit of a...
Sorry, let me just get...
Sorry, quick. But I can keep talking. So this is a little bit different. So this is a mathematical modeling study looking at the potential impact of smoking cessation. So again, and this is the setting for this is Indonesia. So just some background to Indonesia: about 330,000 notified cases of tuberculosis in 2015, and this is actually coupled with very low reporting, which was seen in the national prevalence survey in 2013. So a high burden country. Again, 70% adult male smoking prevalence, about very much lower in the 4% range for women adults, and 75% of these smokers initiate before age 20 years, and this was seen in the 2011 Global Tobacco Survey. So the question we're asking today is really, can we estimate what the impact would be of a smoking cessation campaign on TB disease incidence and mortality in Indonesia? So how do we model this? So this is the point of this is a mathematical modeling study to try to predict this. So the data we use for this is really case control smoking studies. So in these studies we've seen, and there are meta-analyses that show this, but basically a twofold relative TB disease risk for smokers. And what is this is a mechanistic type of modeling that we're doing. So we can model this through very different mechanisms of action. One would be increased risk of infection, also increased risk of primary progression and endogenous reactivation. And these are the two we're going to focus on primarily. So the mathematical model itself is an individual-based kind of an age-structured dynamic transmission model. So we include basically all the demographic data of the country and proper age interactions in this, and look at transmission. And the model includes both age-dependent smoking initiation and cessation, as well as different rates of endogenous reactivation by age. And well, how do we actually get a model that is somewhat realistic, right? We can make a model, but that doesn't really mean anything. So it has to match the data. So here what you see is the calibration to the actual data we have. And so the data is in black with 95% confidence intervals. Now this is mortality data and prevalence data. So on the top you see the time trend in mortality and disease prevalence. So you see that our data are, oh, and I should say the gray is the model output with standard error of the mean. So you see that we managed to match the time trends, both in prevalence and mortality well, but what about the age distribution of prevalence and mortality? Well, you see that below, and you see that for 2014. Now on the left, you see the age estimates of age tuberculosis mortality, and these are IHME estimates. That's the Institute for Health Metrics and Evaluation in Seattle. So we have matched to these estimates, which you see this increasing trend with age. On the right, you see the actual estimates of prevalence from the National Prevalence Survey in 2013. And again, you see this trend of increasing prevalence as age increases. And again, we managed to match this data fairly well. So what would now that we can show that we have a model that realistically matches some of the data, what could we actually do? What could a cessation program actually do? So we modeled 4 different scenarios, and these are age targeted. So you'll see in the black, we're targeting ages between 25 and 44 years, and in the blue, you'll see targeting between 45 and 64 years. Now, again, we look at 2 different scenarios, which are basically just coverage. So one is about 550,000 individuals, where the second is 1.1 million. And this represents essentially, this would be a very, very large scenario, large intervention, but this is just illustrative. So this would be approximately 25% of smokers in the 25 to 45 year age category. And you see the time trend in disease incidence over time, going from 2014 to 2024. And the most interesting thing you see from this, beyond the fact that there is a reasonable size of effect, is that the magnitude of the effect is much larger in the older age groups, in the 45 to 64. And you see on the left-hand side just shows the impact in 2024, both for mortality and disease incidence. And again, it's much larger in the blue, which is that older age category. So what does this mean? What have we shown? Well, essentially, we can show that maximally smoking cessation could impact the TB epidemic. And essentially, we're seeing about 2 to 3% reductions in disease incidence and mortality per year for a very, albeit very large intervention. So this is very large coverage and fairly optimistic assumptions about what smoking cessation would do as far as how risk would revert once individuals stop smoking. The other thing we've shown is that based on our modeling, the impact would be greater at older age in this specific setting. And to illustrate this, if you look below, on the left you see the LTBI prevalence, which is output from the model. And this is by age, and you see this increasing trend to higher reservoirs of LTBI at larger age. On the right, what you see is actually the difference between the baseline and one of the cessation interventions, which was targeted at 45 to 64-year-olds. And you see this broken down in terms of recent infection in blue and in red, older infections, so greater than a few years. And you'll see that the reduction here is actually, the blue is about the same, but you see the reduction in the red, and this is showing that really what you're preventing here is the older infections that are coming from largely from the older age groups. Thank you.
Thank you very much. Very important question about effective tobacco cessation. Yes.
Yeah, very interesting. I remember seeing a model like this years ago globally, and to see it specific, site-specific, very interesting. My question is, you mentioned at the end that you make some assumptions on what the effect on TB reduction would be if people quit smoking.
Mm-hmm.
Do you take into effect that even the people who quit smoking may also be drinkers, have diabetes, and therefore still at an elevated risk?
Right, and that's a good point. And so that's why essentially we for input data, we really try to use case control studies. So we're kind of trying to eliminating that. But ideally, what we want to do is try to incorporate some of that other data into the structure of the model, so we can look more specifically. But at this level of granularity, we just have the smoking. But that's a great point.
Any other questions? Okay. Yes.
So for all of your models, you were using the risk ratio of 2.0 for the relative.
Oh, about for this, what you saw in the results here was about 1.8 approximately.
Okay. Is there any country-specific data on that for you?
Not that I've seen. Essentially, we were going from meta-analyses. That just to give more power, but that would be great to have.
Thank you.
Thank you.
The last presentation is by Z. Moore, and also very interesting issue. This person here. No, on vitamin D. Not here. A pity. Well, then we have lots of time to discuss this further.
Mm-hmm.
Yeah.
So, any questions or anything? I think I'll just make a few comments. First of all, I think I'll start with the title of this session. I think it's fantastic. I don't know who came up with the acronym, but it's always sad to have TB, but I didn't quite see it like that. So I think it's a great title, and what a fantastic variety of presentations we've had. I think looking at health professionals who are treating TB patients and their own smoking behavior to TB patient smoking behavior, looking at cessation, looking at some of the other kind of standard epidemiological studies to look at the association between indoor air pollution and TB. Something about TB and lung cancer, which personally I think is something new for me. So that, and then I think the icing on the cake has to be the modeling study. I think that was very, very nice, neat study. So I think there's quite a lot here to digest, but I think it's all been very, very useful for, particularly for us who work in the area of TB and tobacco and other comorbidities.
I still had a question. Is the person who presented the study on interaction between smoking and pre-existing TB still here? No, it's not here. Okay. I was interested in the biological explanation for this, but nobody else in the audience is aware of that? No. And the confounding, but yeah, he's gone. All right. Okay, shall we close the session then?
Yeah, I just wonder whether there's a question that I have, because several of you work in different parts of the world. So, do you see any change in trying to integrate smoking cessation or tobacco cessation within TB programs? Do you see any movement in that direction? I say that because we have a working group, and which is meeting tomorrow morning, actually, very early, 7:45, and some of us will be there, and we'll be talking about pushing for integration of smoking cessation within TB programs and HIV programs, because it's HIV and TB. So I was just wondering that if there is any knowledge within the room that we could share or take it to the working group, I think would be great. Were you raising hands?
I'm Rumana Haq from Bangladesh. I'm working with Dr. Kamran in a TB tobacco project. So from that experience, the National Tobacco Control Cell and TB program, these are two separate wings of the ministry. So they never meet each other. Both are quite strong, but they never been together to develop any initiative to embed the tobacco cessation within TB program. So we as a NGO and also international collaborator is trying to embed the tobacco cessation within the TB program, but that needs some sort of mobilization from our end. But obviously at different stages it's important to involve, though it's a research work, but we are trying to involve the NTP personnel and the National Tobacco Control Cell people together so that they understand each other and can develop the things. But obviously within the NTP they realize that it's an important issue, but they never tried to embed these other than any external forces encourage them to do so.
I just want to make one comment, somewhat related and unrelated. When you look at SAD that have TB, I think that when we're talking about the smoking cessation, we also think of another area of alcohol use. And I know that in our studies in both India and South Africa, we're seeing a huge proportion of these people who smoke that they also drink alcohol, and they go hand in hand. And often when you get people to quit alcohol or to pull back on their alcohol, they'll also cut down on their smoking. A little bit vice versa as well, but more the other, especially in South Africa, we're dealing with a lot of binge drinking and people going on rages and things like that. If you can control that, it seems to also co-align with reducing smoking as well.
And just to add on it and to add on the presentation from my neighbor in Georgia, I wanted just to say that post-Soviet countries like Georgia, Armenia, with this post-Soviet medical education system, we have the prevalence rate of smoking among even the health workers is very high, and physicians. We conducted study among national oncology center physicians, and the smoking rates were 40%, and they were not even thinking to quit themselves, and they were not raising any awareness about their patients. But coming back to the tuberculosis, we started again, in Bangladesh, it's two separate vertical programs, TB control and tobacco control. But recently, starting from 2014, if I'm not mistaken, we conducted study among the TB providers, among physicians and nurses, just to see what are their thoughts about smoking cessation, etc. And then we realized there is a huge gap to raise awareness of TB providers among tobacco cessation. And then currently we are not only raising their awareness about side effects, smoking counseling techniques, but we also are trying to train them on nicotine replacement therapy so that they can to integrate tobacco smoking cessation as a field into the TB TB control services. And it's it's the beginning of the project, but it seems to be very successful because there is an interest among TB providers.
Yes, my name is Uswa from Namibia. I believe our problem is similar as in other Southern African countries. The TB program is well developed, the HIV program well developed. tobacco control, not so well developed. I can say from my country, it's probably there's one person in that tobacco program which sits under the primary healthcare services and health promotion summit. And it's the same as she had mentioned initially, that we don't talk to each other with this smoking tobacco control person. Now, we also have, in those Southern African countries, there's lots of other there's another bigger priority whenever it comes to TB. That's HIV. All of our messaging has to do with TB, HIV, TB, HIV. And the funders, when they bring in their funding, it's mostly for that TB, HIV, TB, HIV. Now, with smoking, we need to make a case, especially at the global level, high level advocacy, to actually sensitize the program managers that there is indeed a problem, and so that also the funders can follow suit. The other problem that we face in our countries is we do not know. First of all, smoking itself is probably not as big a problem as in the other countries that smoke, but we do not know the magnitude amongst TB patients in most of our countries. We actually don't know. And if we can also get to know what is the magnitude of smoking or tobacco use amongst the TB patients, it will also help. But most of our countries, we have not seen it as a priority. We have not done it. We have lots of other fish to fry, but we need this high level of advocacy to start actually looking at smoking and including it within our TB control. So most of our countries, we don't talk about. Of course, we preach to the patients about stopping smoking, but it's not in the
Yes. Yeah, from our presentations and from the previous conferences as well, I wonder if we could possibly have a report, an integrated report that we could use in order to lobby our own governments, so that they will implement smoking cessation within TB services. Because what I have found out from interviewing staff, and now I'm completing a survey within the big hospital plus 2 step-down facilities, where a number of tobacco items were confiscated from patients, including some of the drugs that they bring with them to the step-down facilities. So maybe if we could have some means of lobbying for strong smoking cessation services, because from speaking to managers in hospitals, they argue on the cost effectiveness thereof, whether implementing smoking cessation services could be of any help at all regarding cost effectiveness, when it comes to funding and so on and so forth. And again, there's a big debate among the clinicians and nursing staff as to whether there's any impact of smoking in relation to TB treatment. So they only prioritize adherence to treatment and not so much on smoking cessation, although they do talk about it, but there are no practicalities of helping patients. So we need a document to lobby if possible.
I think just to answer that, there are some documents from WHO and some monographs and also some guides to smoking cessation among TB programs. So I think the documents are there, it's getting them out to the right people and actually having people pay attention to them, as you were saying.
Yeah, and part of the problem is indeed those pillars, because when you go to the TB people, they say we don't have anything to do with non-communicable disease, and you go to that one person, like you say, who's responsible for tobacco cessation, and they say, well, we have nothing to do with TB. So you are actually being sent from pillar to post, even when it comes to getting ethics approval for studies, etc., because it's all different people. So that's one of the problems. And you often have HIV, TB, and tobacco smoking, all different people. Yeah, it's a problem. Okay.
So we can let them go early?